This is Jean Berger. He was a French pathologist. So pathologists are doctors that look at tissue biopsies. And in 1968, he was the first one to describe this condition. And he described it because he was able to have access to a special new technique that allowed you to stain kidney biopsies for IgA. And he was identified that there were a group of people that had IgA stuck in their kidneys. And so this disease, if you go Googling, which everyone does, you will see Berger's disease. And that's because this was the guy who first described it. But now we call it IgA nephropathy. Go to the next one. But IgA nephropathy has been around for a lot longer. And these are the two oldest cases where IgA nephropathy has been diagnosed. And these are from people from the 18th century. So we've got John Paul Jones, and we have Prince Joseph Habsburg. And if you were important in the olden days, you had your organs preserved. And people can go back and look at those organs and then do new tests to see what people died of. So is there anyone, I've asked this before and some people do know, has anyone ever heard of John Paul Jones? So he's the father of the US Navy. And famously, he invaded England once. It wasn't successful, but he tried. And those are the two oldest cases of IgA nephropathy that have been recorded. If we go to the next one. Even though it's only 50 years old, this disease, it is now recognized across the world as the commonest pattern of glomerular nephritis in the world. If we go to the next one. But it's rare. One of the things that comes out when we have these days is most of you will never have met another person with IgA nephropathy. You'll sit in a kidney waiting room. By and large, no one talks to one another, as people don't, and you won't meet another person. And that can be quite isolating because you've got no one to compare stories to. And one of the great things about days like this is you get to meet other people, you get to share stories, and you get to find out that it's not just you. Next one. The other condition that's often confused with IgA nephropathy is IgA vasculitis or Henoch-Schonlein Purpura. So does anyone in the room have this condition? Because there's often a couple of people that do. And people talk about it on certainly the UK Facebook page and want to know what the difference is. And I'm just going to give you a little a bit of information about this. So if we go, so that's Mr. Henoch and that's Mr. Schonlein. And they are labelled as having described this condition in the 19th century. But actually, if you go to the next slide, this chap, William Heberdin, described it about 50 to 100 years earlier. And his description covers all the aspects of this condition. So IgA nephropathy is a condition that only affects the kidneys. Whereas IgA vasculitis, while it looks the same in the kidney, no, sorry, did you go back? You can see here what he wrote about this 5-year-old boy. So it's a disease that commonly affects children, and they have pains and swellings in various parts, principally the joints, pain in the tummy, urine that may have blood in it, and a rash on their legs and buttocks. And if you go to the next slide, you'll see this is the rash that's typical of Henoch-Schonlein Purpura. So it's a non-blanching, red, raised rash, typically occurring on the legs and the buttocks, commonly in children. And when we talk about this, there's often people in the audience who think they've got IgA nephropathy who say, well, you know, I had that rash a couple of years before someone realised I had anything with my kidneys. And so there's often a bit of interchange between that. But this is what IgA vasculitis is. If you go to the next one. And that rash can affect the inside of the organs, and in this case, the gut, to give tummy pain. Next one. And it can cause swelling of the joints. Next one. And of course, it can cause problems with the kidneys, which are identical to IgA nephropathy. Next one. And so you've got this conglomeration of symptoms of joints, kidneys, skin, and bowel with IgA vasculitis. Next one. And IgA vasculitis is, in fact, the commonest vasculitis, so the commonest inflammation in blood vessels in children in the world. But again, it's rare in the UK. If we go on. So I'm just going to give you a little bit of background about the kidneys. So the kidneys sit here in the lower back, in the loin area. We go on to the next one. And in IgA nephropathy and IgA vasculitis, both kidneys are affected equally. Even though when we do a biopsy, we biopsy just one kidney, we know the disease affects both kidneys exactly the same way. We go to the next one. So the kidneys are really important for a number of different reasons. So they maintain how much salt and water we have. They get rid of all the waste products your body produces every day. They make hormones, they make vitamin D, so they keep your bones healthy. And they produce something called erythropoietin, which is a hormone that keeps your blood count up and stops you from becoming anemic. And they control your blood pressure. So you will not be surprised that every time you go see a nephrologist, we are absolutely obsessed with your blood pressure because the two are intimately linked. And we want to know whether your legs are swollen, because that's to do with salt and water retention. We go to the next one. And if you think about the kidneys, they process 1 litre of blood every minute of every hour of every day, all your life. So that's 180 litres of fluid that's filtered every day. So they clean your entire blood at least 60 times a day. But 99% of what's filtered actually comes back into the body. So not only do they filter it, but they very finely fine-tune the urine to make sure only the things you don't need are peed out and everything else is kept in the body. We go to the next slide. And to do that, each kidney is made up of filters, and those filters are called glomeruli. And there are around 1 million of those in each of your kidneys. And to do all this filtering, they need to have a very wide surface area over which they can filter the blood. But it's very, very well compacted. And if you were actually to lay out all the tiny blood vessels over which this filtration occurs, they would stretch over 19 kilometers. So if you go to the next slide. So just to put that in perspective, if we took half of the Iga Nephropathy group from Leicester and laid out those blood vessels from all their kidneys in one line, we would go the whole length of Hadrian's Wall. If we just took Karen's kidneys, laid out the little blood vessels over which the filtration, it would go 50 times around the outside of either Hampden Park or Murrayfield. So these are organs that are this big. But within that, you have a system that is so finely tuned that it has such a complex array of blood vessels and surface area that allows this filtration to happen every second of every minute. If we go to the next slide. So who's had a kidney biopsy? Who's done kidney biopsies? It never hurt me once. But I guess you all have different stories to tell. But this is a kidney biopsy. The only way we can diagnose IgA nephropathy is with a kidney biopsy. We don't have any blood tests or urine tests at the moment. And so this is what your kidney biopsy looked like. So this is a magnification of the biopsy needle, and there's a little sausage of kidney tissue that we get, and we cut that up and we look at it under the microscope. We go to the next one. So this is what we look at, and we have a meeting, and I'm sure Colin does as well, once a week, where we look at all the kidney biopsies and we look at what we see. And this is a normal kidney biopsy, and these little round things here are the little filters. So even though there are 1 million, we normally get about 18 or 20 to look at in a kidney biopsy. But we look at those because we can make a diagnosis based on the changes that happen there. And what happens in IgA nephropathy, if we go to the next slide, is each of those filters is stuffed full of the protein IgA. And this is the staining that Jean Berger first used to make this diagnosis. And you can make out these little balls of cells. Every single filter in both kidneys is full of this protein. Okay, and if this was a normal kidney, you wouldn't see any at all. So you can see it outlining all the little filters. IgA is one of your antibodies. So everyone has it, and it is very, very good at stopping bacteria entering the body. So in your spit, in your saliva, in the mucus that comes in your lungs, in the intestinal fluid that comes in your bowel, it's full of IgA, and it's there as an antiseptic paint to stop bacteria getting into the body. In IgA nephropathy, for some reason, this IgA makes its way into the bloodstream and then gets stuck in these fine filters. And when it gets stuck in these fine filters, it can cause those filters to become inflamed and scarred and damaged. If we go to the next one. So kidney diseases that affect the filters are known as glomerular nephritis or glomerular nephritis, and there are lots of different types. One of the things we've done is we have done some research using the conversations that have happened on the UK Facebook page. And we've asked, and we've looked to see what people are talking about. And one of the things that people talk about is terminology. Because doctors are absolutely fantastic. If we can think of a complicated word to describe something that's simple, we'll use it. And we forget. So we forget when we're talking, and and every second word we're using something that is not common for us, but will be difficult for people to catch up on. So we use the term glomerular nephritis all the time. You put that down on a piece of paper, it'd be very difficult to work out what on earth we're talking about. But that is an inflammation of the fine filters, and there are a whole range of different causes. IgA nephropathy is one of them, and it's the most common. We go to the next. So how do we know you've got IgA nephropathy? Well, some people pee fresh blood when they pick up infections, and that's pretty obvious. And that will often make people go to the doctors, and then that'll precipitate a whole series of investigations. Other people don't do this, and for some reason have had their urine dipsticked because there's blood there, but no one can see it. And this is, in fact, the commonest way we find people. And normally this is at the time when people are having a medical because they're changing jobs, or they want to get a mortgage, or they're starting university, or they're having a well man or well woman check. So they go along feeling completely fine. There's a blood dipstick test, suddenly there's blood and protein, and that then precipitates referrals to the nephrologist. And the people don't know they're unwell at all. We go to the next one. So I really like this, but again, I'll just explain what it is. So this is a very, very fine, detailed picture of one of those filters, just one of them. And these are those little blood vessels over which the filtration occurs. And this is a red blood cell. And what you can see here is rather like me this morning putting my trousers on. You can see a red blood cell squeezing its way through the wall of that blood vessel and ending up in the urine. And so when we dip your urine, we are seeing very low levels of blood appearing in the urine. And that's because there's some minor damage to the filters, and these blood cells are able to sneak through. In health, that doesn't normally happen. In IgA nephropathy, it does, and therefore that's what we're picking up. We go to the next one. So we may see blood in the urine, we may see protein in the urine. We go to the next one. You may have had your blood pressure checked, and someone finds your blood pressure is elevated, and that then triggers a check of your kidney function, a dip of your urine, and then you end up going to see a hospital nephrologist. Next. Or you've had a blood test and your kidney function's abnormal. As you can see, all of these are not related to you having any symptoms at all. These are things that often come out of the blue. So often we see patients and they think they've all been fine. And suddenly someone lays the bombshell on them, oh no, you're going to have to go see a kidney specialist because something's not right. And they say, well, I don't know why, I'm feeling absolutely fine. And still feel fine. None of these prove you've got IgA nephropathy. You have to have a kidney biopsy, I'm afraid. Lots of people around the world are working on tests to try and mean you don't need a kidney biopsy, but we're nowhere near close yet. Okay? So what happens if you've got IgA nephropathy? If we go on to the next one. So, well, sorry. So what about, no, that's, so, yeah, keep going, that's fine. So this is the proportion of kidney biopsies where IgA nephropathy is the diagnosis. And Colin, who's here from Glasgow, who's going to talk about transplantation, has done some very important research looking at this across the continents. And what we see is that as you move from the west to the east, IgA nephropathy becomes far more common. So it's rare. It's regarded as a rare disease here, as is IgA vasculitis. If you go to China, I'm just going to put this in perspective. It's estimated there are as many people on dialysis in China as there are in the whole of Europe. In China, 1 in 4 of those people is on dialysis because of IgA nephropathy. It is a massive public health problem. In the UK, it's very, very much less of an issue in terms of the numbers of patients. So it increases massively as you move from the west to the east, and we don't really understand why. We go on. It's so common that even the dogs get IgA nephropathy in Japan. Go on. In the West, you're 3 times as likely to get this disease if you're a man than if you're a woman. If you go to the East, we go to the next one, it's equal. In fact, the ladies may well get it more than the men, and we don't really know why that is. Carry on. So what can happen? Well, we have a very mixed bag. We can have people who have all this IgA in their filters and lead a completely normal life with absolutely no impact on their kidney function at all. And we have people who have IgA nephropathy and ultimately need dialysis or a kidney transplant. So it has a very, very variable course. Should we go to the next? So what can happen? Well, it can go away completely, but that's much more common in kids rather than in adults. But it does happen. Next one. The commonest situation is it just stays around for years, and it might cause a little bit of kidney worsening of function, but you're always going to have blood and protein in the urine. And one piece of advice is if you have IgA nephropathy, you've got blood and protein in the urine, you go to the GP unwell, they dip your urine, they're going to diagnose a urinary tract infection, even if you don't have one, because you've got blood and protein in the urine. And the commonest cause of blood and protein in the urine is a urinary tract infection. But actually, you're always going to have that. So you just need to be aware of that. Next one. The kidneys can lose function slowly. And by slowly, I'm talking 5, 10, 15, 20 years. Carry on. And in some people, the kidneys can stop working altogether. And it's estimated that at 20 years, there's about a 20% chance of kidney failure, by and large, in Western countries. Okay? And if you have a kidney transplant, it can come back in the kidney. And usually it comes back slowly, as it did in the original, in your own kidneys that you started with. Carry on. But everything normally happens very slowly. So there's lots of time to have discussions and to try and do things for the disease. In IgA vasculitis, that is a little bit more of an aggressive disease and can cause kidney failure quicker. But again, it's a rarer condition than IgA nephropathy. Okay? So how can we predict what's going to happen? Yep. If you've just got blood in the urine and no protein, or you've just peed blood and you've got no protein, you're at low risk of any particular problems in the future. Do you go on? The key things we know, the more protein you have in the water, the worse the outcome. The higher your blood pressure, the worse the outcome. And if you've already got evidence of kidney scarring by an abnormal kidney blood test, the worse the outcome. And that was where we were really up until very recently. So if we go to the next one. We've developed a way of looking at the kidney biopsy called the Oxford classification, which you may or may not have heard of. When you have your kidney biopsy done, the pathologist will score it. And we know the features on that biopsy that will tell us whether you're at likely risk of future kidney damage. That doesn't exist for IgA vasculitis yet, but we're looking to validate that in IgA vasculitis as well. Okay? So how well can we predict what's going to happen? If we go to the next one. So at the time of biopsy, we can do quite well, and that's really changed since the beginning of this year. So if we go, so the international IgA nephropathy community, led by someone called Sean Barber in Canada, has collected together data from thousands of IgA nephropathy patients at the time of their kidney biopsy, put all the clinical data together to work out whether we can use that data to predict the likelihood of an individual person ending up with problems with their kidneys. And there is now an app, and I have the app on my phone, and anyone can have the app, and you can ask me about it during the coffee break. But here it is on the screen, and you put in these features at the time of your kidney biopsy. It's not validated 3, 4, 5, 6 years later, although that's working on that at the moment. So you put in your GFR, your measure of kidney function, your blood pressure, how much protein you've got, how old you are, what race you are, whether you're on ACE or ARB tablets, your kidney biopsy score, and whether you've already been started on immunosuppression. And what that will do is it then gives you your individual risk of being on dialysis or having a halving of your kidney function up to 5 years from that time. And I use this all the time now with my patients. It can only be used at the time of kidney biopsy, as I say. But hopefully this will evolve so that if you're 3 years from your kidney biopsy, there'll be some data that you can put in that'll tell you what's likely to happen further on. Okay? It's not been validated in IgA vasculitis, but that work is happening as well. We go on again. As doctors, we're always taught the best way to predict the future is to look at the past. So if you've got 5 years of kidney function data, I can look at that and I can see what's happening and what's changing, and I can estimate then what's going to happen over the next 5 years. And in the olden days, when I was a trainee, we used to have graph paper in everyone's notes, and we used to plot what your creatinine level was, and then we'd draw a line and we'd work out what was likely to be happening in a predictable fashion. Now, of course, computers can do that, and in fact, you can do it yourself. So if you go on to the next. So who's on patient view, or who's heard of patient view? It's a fantastic thing. So everyone in the room has, which is brilliant. This was developed in Edinburgh by Neil Turner, I think, really drove this, and this is a way for kidney patients to access their blood results. And often my patients get to see their blood results before me, but it allows you to graph and plot out what's happening with your kidney function, with any of the things that are measured. And it is an absolutely fantastic resource for people with kidney disease to be able to see what's happening to them and have some element of control and understanding about how their kidney function is changing. So if you can register online now, and it happens very, very quickly. But I thoroughly recommend, if you're on Facebook and you're not on Patient View, is to investigate whether you want to, because it's a really great innovation. Okay? So what's the cause of IgA nephropathy? That's the million-dollar question, isn't it? Next one. And I'm afraid that is the answer. We don't know. There are lots of people working on it around the world. We are getting much better at understanding it, and that's led to a whole range of potential new treatments that Chike is going to talk about. But we haven't got enough of an understanding to be able to say for a particular patient, this is what's happening in you as an individual. Go on to the next one. We know the IgA that you produce is somehow subtly different because it sticks in the filters, whereas everyone else's IgA doesn't. And so certainly the work we're doing in Leicester and in other centres is really focusing on the very, very fine detail of that IgA molecule. So we go to the next. And so we've been doing some work looking at the actual structure of individual molecules. Now, normally Phil's in the room because that's Phil's IgA. So Phil Smith is a patient from Leicester who helps run these events but can't be here today. So we have looked using the most precise methods at what the three-dimensional shape of an individual IgA molecule is like in IgA nephropathy. And we're starting to get an understanding of how that might change. And because these proteins change their shape, it means they alter how they behave with other proteins. And you can then start seeing a domino effect, that there's a change in this protein, which means it then interacts with a whole series of other proteins, and that's what ultimately causes the disease. Go on to the next one. So we're fortunate enough to have Laura here. I do like that photo, very fetching. And this is the view from your lab window, I think, is that right? From Edinburgh. So Laura's going to talk about the research she's doing here in Scotland in IgA and other diseases, but there are lots of research, there is lots of research happening. I'm not going to go into it in too much detail, but suffice it to say we are getting a better understanding of where this IgA is likely coming from, which means we can target therapies. So if we go to the next. And the one thing that is becoming more and more obvious is that we think this kidney disease is caused by an abnormality in your gut or your lungs, in that the immune system that produces this IgA that protects you from infections is actually abnormal. And that abnormal IgA is spilling into the bloodstream and then affecting the kidneys. And what's interesting is we're starting to use drugs to target the bowel to treat the kidney disease, to switch off the gut that then protects the kidneys. And Chike will mention a little bit about that. But this is a really new and exciting area in terms of the kind of therapeutics that we're starting to develop for this condition. Okay? So what's the right treatment? Yep. If I said this once, I would say it 100 times. I guarantee you the best evidence available for treatment of most forms of kidney disease, but particular IgA nephropathy, is to make sure your blood pressure is controlled. Who measures their own blood pressure at home? Excellent, good. Not obsessively 4 times a day, I hope. So perhaps once a week or so. But getting your blood pressure controlled, we know, will protect your kidneys against further damage. It may not stop them getting worse, but it'll stop them getting worse slower. And you can control your blood pressure with a whole range of different maneuvers. Exercise, be the ideal weight, blood pressure reducing tablets, salt restriction. All of these things will help. Next slide. Now, I couldn't find a picture of your dietitian who's coming. So clearly the nephrologists are no problem putting their faces on the internet. But just go back, Karen. So we have one of Colin's team who's coming to talk this afternoon about diet and lifestyle, because this is critical to maintaining both a healthy lifestyle, but also is critical at protecting your kidneys. Most people, if you talk to a patient about what a renal dietitian says, it says that if it tastes good, spit it out, because it's got too much salt and it's clearly got things we shouldn't have. But hopefully we'll dispel those rumours this afternoon. Okay, next slide. Who's on one of these drugs? I would imagine every single one of you is. So it's either an ACE inhibitor or an ARB. So ACE inhibitors all end in pril, and ARBs all end in sartan. And these drugs are what we would go to first for either controlling blood pressure if you have high blood pressure, or if you have normal blood pressure and you have protein in the urine, we would put you on one of these drugs anyway, because they're very good at reducing the amount of protein in the water. Clearly, if we're giving someone who has normal blood pressure a drug designed to reduce blood pressure, we have to be cautious, and we gently increase the dose, because we don't want you falling down because your blood pressure's gone too low. But if we can, we will have you on one of these drugs, because it will reduce the amount of protein coming out in the urine, which is a good thing for IgA nephropathy. Okay? So is there a specific treatment for IgA? Well, unfortunately, we don't have one at the moment, but there are some exciting drugs being tested around the world in clinical trials, which, as I say, Chike will tell you about. Okay? Next slide. Some people may have been on steroids in the room. Some people may have been on a drug called mycophenolate. Some people may have been on other drugs. We really don't know for sure whether these are effective in IgA nephropathy. Some people believe they work, some people believe that they don't. And when we have this difference of opinion, it's very much dependent on the relationship between the nephrologist and the patient as to whether they're prescribed these tablets or not. If we go to the next slide. What we do know, though, is that we are in a very good place in terms of clinical trials, and there are a whole range of therapies being tested in very, very robust ways that will give us a clear answer on what will and won't work in IgA nephropathy. And that also involves the steroids. So we will have absolutely definitive data that will help us guide what treatments are available for patients. We go to the next one. So how are we going to understand about IgA nephropathy? Well, this is just a plug for the work that we're doing. Hands up who's in RaDaR or who's heard of RaDaR. Okay, right, so we've got some work to do. So RaDaR is the UK Rare Disease Registry. It is an absolutely fantastic innovation, but it's sponsored by Kidney Research UK and a number of other organisations. And what this means is that if you sign up for RaDaR, and IgA nephropathy and IgA vasculitis are in RaDaR, what you're signing up to is allowing, every time you have a blood test through the NHS, that blood test goes into a registry. And we also collect information about your medications and about your kidney biopsy. And at the moment, so we have a handout, which you may or may not have yet, but that's got RaDaR, that's got some information on RaDaR. There are over 3,000 patients with IgA nephropathy in this registry. And what that means is we can track what's happening with patients with IgA nephropathy. We can look at the rate of kidney function decline in patients. We can look at factors that might influence that. Factors such as living in Scotland versus living in England, where you live in Scotland, all those kind of things, whether you're male, whether you're female, how old you were when you were diagnosed, all those things can be looked at. No other country in the world has a registry like this. And the beauty of the NHS is there is one healthcare provider. which means everyone goes to the same system, therefore all the results come into this. And this is an absolutely fantastic resource. So if you are not registered, please see me and we can talk about it and we can put you in touch with the local team who can consent you for that. In addition, I've generated an international version of this, which I'll talk about in a second, where we are trying to mimic this in other parts of the world. So we can see what happens with IgA nephropathy patients in the UK and what happens to IgA nephropathy patients in the Philippines. And if we collected the data in the same way, we can compare and see how things are different. We also have, I don't think we quite appreciate how an amazing healthcare system we have and an amazing NHS that's supportive of research. So we have an investment in something called the NIHR Bioresource. So this is a centrally funded initiative that allows patients to consent to be in the bioresource. They have blood taken, they will have their genetics looked at, and they will consent to be allowed to be called back for research studies. And so I have IgA nephropathy and IgA vasculitis in the bioresource. And my hope is that over the next 12 to 18 months, everyone with IgA nephropathy in the UK will have been offered the opportunity to be in RaDaR and hopefully said yes, and offered the opportunity to be in the bioresource and said yes. And then what we have is we have a group of patients where we know exactly what's going on in their genetics, and we know exactly what their clinical disease looks like, and we can start teasing out why people behave differently in different ways. And we can then ask some of those patients to come back for research studies. They don't have to if they don't want to, but they've consented to be contacted. And so this is an absolutely fantastic resource, and it's not cost me a penny. Well, I've paid my taxes, but it's not cost, this is centrally funded because it's seen as being so important. And I think this is just a really great advert for the kind of investment we have in this country in medical research. So we go to the next slide. So this is me in Singapore. So this is the Southeast Asian GN group. And everyone here is interested in IgA nephropathy. And so we are setting up this international RaDaR in Singapore, in the Philippines, in Malaysia, in Thailand, and in Indonesia. And these are interested nephrologists who want to collect the same data we're collecting in the UK. They're going to have to manually type everything in, but they're committed to do that so we can start understanding how the disease is different in different parts of the world. If we go to the next one. And this is Sasina, who's doing her PhD with us, who's based in Vellore in southern India, and Urmila, who's based in Hyderabad in northern India. And both of these nephrologists are setting up and getting approvals to collect data on their patients. So we can start comparing UK, Southeast Asia, and Indian patients. We go to the next. We also have links with China. Don't forget, 1 in 4 patients on dialysis in China has IgA nephropathy. We have 3,000 patients in the UK-wide RaDaR registry. One of my collaborators in China has 14,000 patients on his books with IgA. So oh, that's 3,000. He laughs at me. 14,000 without even thinking. So we have a sister renal centre sponsored by the International Society of Nephrology based in Nantong, and they're going to be recruiting patients as well. We go to the next slide. So this is my view out of my window in Leicester. So if you haven't been to Leicester, this is exactly what Leicester looks like, or at least Skegness. But the future is looking incredibly bright certainly in terms of our understanding of IgA nephropathy. And that understanding is leading to companies wanting to look at testing their drugs in this disease. Because 5 years ago, if I'd put that picture up, it would have been empty. No one was interested in IgA nephropathy in terms of new therapies. Now, because of the increase in our understanding of the disease and a change in the way we're looking at drugs in IgA, it is incredible. I'm getting called probably once a month for a new drug that people want to think about testing in IgA. And that's a fantastically exciting place to be. We go to the next slide. But of course, none of this is possible without the involvement of you guys. So our research is very much driven by the patients that have the disease. So Tara, one of my patients, sat in clinic one afternoon and said she's got IgA, and she said, you know, I'm looked on the internet, I've She is in a band. She has a very big web presence. I've looked on the internet for information about IgA nephropathy, and I've got myself so confused because there's so much different information. I've gone on Facebook, I've looked at patient groups, and what they're talking about has no relation to me in the UK, because they're talking, a lot of people are talking about their experiences in other parts of the world which are very different. And so she set up the UK Facebook group, which I think has been a great innovation, allows people in the UK to chat about IgA nephropathy or just observe conversations to learn a little bit more. And that really then triggered the idea of having patient information days, which Karen has led fantastically. And so we have had information days up and down the country, and we opened up our laboratories in Leicester. And these are all patients, this isn't the whole team, these are all patients with white coats on who've been to see what we do with your samples. Because anyone who's visited me in Leicester, so I think Siobhan came on Monday, you don't leave without having at least 5 blood samples, your urine collected, your saliva collected, and anything else we think we can get away with. Because that's what we need to do our research. And I think it's only fair that you guys get to see the other end of the story, which is you come into our labs and you see what we do with those samples. They don't just put in a freezer or forgotten. So people came in and they saw how we grow kidney cells, what we do with blood, how we analyze urine, the kind of technology that we use to investigate kidney disease. And so hopefully we'll run another one of those next year. But I think it is really important because we couldn't do our research without you guys being involved in our research, because we work very much with human samples, and we need the goodwill and the time of patients to be able to come in and give us their samples so that we can use those to study. Next slide. So this is the IgA group. This was at the international meeting where we presented. I'm going to finish there. I'm happy to take any questions or any questions from Facebook. But of course, you can, if you don't want to shout out, you can always catch me at coffee. So thanks very much. It's always great because no one asks a question, and then when I go for a coffee, there's a long queue. So,
and also because we've gone over time.
Yep. Okay.
But there's a question there.
Okay. Yes.
So when I had my biopsy, I was told I didn't have the rash of vasculitis.
Yep.
But I was told I did have it. Does it go away or does it stay? Or I had no signs or symptoms of vasculitis, but it did show in the biopsy.
So this is doctors being fantastically useful at the terminology they use. So to have IgA vasculitis, you need to have other symptoms outside of the kidney. But you can have lots of inflammation that can be labelled as in the kidney. That doesn't mean to say you've got IgA vasculitis unless you've had the rash or you've had the tummy pains. But so what's happening in the kidney, if we took the kidney biopsies from people with the rash and without the rash who just had IgA, we wouldn't be able to tell by looking at the kidney one disease from the other. So if you haven't had the other symptoms, we would regard that as not being IgA vasculitis and being IgA nephropathy. Okay, I think we've overrun a little bit, and I've been told by the boss I need to shut up now. So who's next?